Welcome to NU 623 Adult Healthcare. This is Unit 1 Presentation 2, and we're discussing coronary artery disease and acute coronary syndrome. Please follow along with the associated chapters in your book for detailed information about these disorders. There are contributing factors as well as risk factors associated with coronary artery disease. Please pay attention to your patients who are either diabetic, obese, or have a lot of stress, and consider your modifiable risk factors in these populations. Make sure you're managing their hypertension and their hyperlipidemia appropriately, and counsel them on smoking, sedentary lifestyles, and use of medications that can cause extra risk factors for cardiovascular disease, such as estrogen replacement therapy for your menopausal patients. Obviously, there's some risk factors you can't modify, so just be aware of those risk factors. Patients suspected of coronary artery disease can present with angina, shortness of breath, or syncopal episodes, but they're usually symptomatic until about 75% of the artery is narrowed. Your physical exam findings may include peripheral pulses, carotid auscultation, jugular venous distension, capillary refill, and blood pressure. Keep in mind that nerve damage related to hyperglycemia can blunt symptoms in a diabetic. And then you need to try to determine the extent of the coronary artery disease and the etiology with diagnostic testing. Your EKG and your high sensitivity CRP can be done in the office, and then if warranted, you'd move on to stress testing. Reserve the pharmacological stress test, which uses vasodilators or beta agonists for your patients who are unable to exercise. And then continue to monitor for progression of the disease and potential complications, including MI, peripheral vascular disease, and cerebrovascular disease. Risk factor management is used for primary prevention, but it continues once a diagnosis is established. Medication therapy is used to both control symptoms such as chest pain and prevent cardiovascular events such as a stroke. When pharmacological therapy fails, then invasive procedures may be required. Here you would be referring to cardiology for this, and they would direct the treatment plan. Your follow-up is going to be variable and based on patient symptom management and progression of the disease process. Cardiology referrals would be given for coronary artery disease assessment and management of the angina. Acute coronary syndrome comprises different etiologies for chest pain. They all stem from one form of myocardial ischemia. What's really important is that you have to determine whether you have stable, unstable, or variant type of chest pain. Stable chest pain is going to be predictable with exertion, and it's going to be relieved with your normal course of nitroglycerin. Unstable is going to be occurring at rest, usually is prolonged more than 20 minutes, or it could be an exacerbation of stable chest pain where it is increasing from previously, or it could be brand new chest pain. In unstable angina, what you're usually looking at is you're looking at a myocardial infarction. It could be evolving, or it could be in the middle of it. Could be close to the end of it. You just never know. When you do your EKG 12 lead, you'll be able to see certain indicators that will show you whether this is an ST segment elevation type of an MI or a non-ST segment elevation. With the non-ST elevation, this is usually going to be a subendocardial type of infarction. You're going to have some positive biomarkers like your troponins and your CKMBs. Then you're not going to see any of the ST segment elevation or any Q waves on your tracing, but you may have some ST segment depression or some T wave inversion. On your STEMIs, these are transmural infarctions. You're You're going to have your positive biomarkers again on your labs, and your ST elevation will be showing on the EKG, or you could have a new left bundle branch block. You may have Q waves and you may not. In your variant form of chest pain, they're really just coronary artery vasospasms. People with acute coronary syndrome are typically going to present with complaints of angina, dyspnea, palpitations, dizziness, diaphoresis, and nausea. Now, they may not be having those while they're in your clinic setting, but they may complain that this happened prior to the visit. Diagnosis likelihood is based on your patient history, also your physical exam, and the 12-lead EKG that you're going to perform in the office. You want to do this before you do any additional testing. Like I said earlier, your EKG may have some ST segment changes, could have some T wave inversions. Could be some pathologic Q waves. You might see a left bundle branch block, or you may see other types of arrhythmias or rhythm disturbances. Or if they're not having any chest pain at the moment, it could look totally normal. After you do your EKG, your next step would be to get a chest x-ray, because you want to make sure there's not a new onset of heart failure or a worsening of heart failure. And you want to check the size of the heart. This also rules out any other causes of chest pain. You would want to only do the echo if you felt it was necessary based on the EKG findings, or you might be sending them off to the ER at that point. As far as a stress test, if your EKG shows the need for that, you can do a EKG stress test, exercise or pharmacological stress with nuclear imaging or with echocardiography. And then coronary angiography is something that would be initiated by the cardiologist. There are some lab tests that are important. You want to get a CMP, check your kidney and liver functions, check your lipids, see what the cholesterol looks like, and then you can check the cardiac biomarkers, the troponin and the CK-MB. But a lot of times these are left for the hospital to do, because you're not going to get these results back right away. A BNP can also be done if you suspect heart failure. This just reiterates how you're differentiating stable and unstable angina. As you're looking at the 12-lead EKG, again, you may have some ST depression or T wave inversion, or could be normal, and the pain is relieved by nitroglycerin. So this would be your stable. Your unstable, you could have ST depression or T wave inversion or ST elevation, the new bundle branch block, or you could have Q waves, and the pain is not relieved by nitroglycerin for unstable. First of all, if you have any patient with active chest pain, you definitely want to send them to the ER for immediate evaluation. You're not going to be able to do everything you have to do to totally rule out an MI based on an EKG alone, because your 12-lead may or may not show any EKG changes, and then MI could still be occurring, or there may be arrhythmias going on. So it's really necessary to get those cardiac enzymes, the troponins and the CK-MB and the myoglobin. Please make sure you look at the 12-lead EKG, assessing axis deviation, and the approach to EKG interpretation in your book on the pages that are listed. Remember that troponins are going to rise 2 to 4 hours after an MI, but they stay elevated for 7 to 10 days. Your CK-MB rises in 48 hours and lasts about 48 to 72 hours. If you're having repeated episodes, like if they're having a bunch of small MIs, this is better detected with the CK-MB. The myoglobin rises within 2 hours of MI, but it's nonspecific for cardiac muscle. So your other two biomarkers are more important. There are other nonspecific labs listed on this slide that you should consider getting. The WBCs, sometimes you'll see rise to 12 to 15,000 in the presence of an MI, and the SED rate can rise too, but it's not a specific marker for cardiac muscle. This is just showing you what a normal 12 lead EKG should look like with the different leads. So you can see the P wave is typically upright, but it can be inverted in leads 3, AVR, AVL, and V1. Your T wave is normally upright in 2, 3, V3 through V6, then downward in AVR, and it can be variable in the rest. The ST segment should have minimal deviation from the isoelectric line. Your Q waves should be less than 0.04 in duration and less than 4 millimeters in depth. Your PR intervals and your QRS complex durations should be constant. And then the axis should fall between 0 and plus 90 degrees. This diagram shows you some EKG changes that can occur with cardiac damage. Your EKG can reflect either myocardial ischemia, injury, or infarction. In ischemia, you'll see some T-wave inversion. In injury, depending on if it's a STEMI or a non-STEMI, you may see ST segment elevation or depression. And in infarction, you can see pathologic Q waves, but they may not show up for 1 to 3 days. Your axis deviation, a 0 to a negative 90 degrees is going to be a left axis, and a positive 90 to a positive 180 is going to be a right axis. In angina alone, you can see ST segment depression with or without T-wave inversion, peaked, flattened, or inverted T-waves. And just be aware that if you have a posterior wall MI, this requires a posterior EKG, which does look different and is read a little differently. You may see ST segment depression and upright T waves. You can find this diagram in your text. It just further emphasizes the ST segment versus the non-ST segment elevation. With the EKG tracing that you would expect to find for each, and the depth of the cardiac muscle that's affected by each type of MI. Management of your conditions will depend on whether you've determined they were stable, unstable angina, or MI, or a variant angina. In stable angina, you're going to use nitroglycerin, sublingual, long-acting nitrates, beta blockers, and aspirin. Your long-acting nitrates can include either topical or oral forms. When you have an unstable angina or an MI, in clinic, you will only be able to have access to an EKG. So if that EKG is abnormal, then, and the patient's having chest pain, you need to start them on O2, give them aspirin and sublingual nitroglycerin, and call for emergency transport to the ER. It will only be through the biomarkers and the EKG that they're going to be able to distinguish what's going on. If it's a STEMI, they need emergent intervention. A non-STEMI can wait up to 48 hours to have an angiogram. In variant angina, you may see some ST elevation on the EKG, but that can resolve if they're given nitroglycerin or calcium channel blockers. This treatment flowchart of unstable angina is actually listed in your book, so you can read this yourself and study it. This picture is also listed in your text, so make sure you look at each box and understand this as well. For follow-up, if you have a patient with stable angina and they have not very good control of their cardiovascular risk factors, make sure you're seeing them every 3 months to be monitoring for progression of disease and comorbid conditions. Keep a good control on their hypertension, their obesity, and their lipids, and consult cardiology to assess the nature of angina and potential progression to unstable angina. In unstable angina, we've already talked about that at depth. You're going to immediately refer to the ER. They're going to consult and have a follow-up with a cardiologist. But after discharge, they really should be on a beta blocker, some nitro sublingual, long-acting nitrates, aspirin, statin, an ACE if they have left ventricular dysfunction, and a diuretic for hypertension. Here are the references that were used to make this portion of the presentation. I also want to make sure that you're directed back to your module in Canvas because there are links to help you understand rhythm interpretation.